Good afternoon. My name is Jennifer Cardellini. I am the Director for Consumer Information at Benjamin Rose Institute on Aging and the Co-Project Director for the Administration for Community Living Project, Expansion of Dementia-Capable Communities within Urban and Rural Settings in Ohio, using evidence-based and informed programming. Thank you for joining us today for Benjamin Rose Institute on Aging's webinar, presented as a part of this new Administration for Community Living Project, Dementia, Not a Normal Part of Aging. Today's webinar will be recorded. During the webinar, you may submit a question at any time using the control panel on the right-hand side of your screen. We have staff monitoring the questions box to convey your questions to our presenters and to answer any technical questions you may have. Our team is also monitoring the chat. We are conducting an evaluation of our dementia education sessions as a part of this project to help us improve dementia education programs and to help us think about future services and supports for individuals living with dementia and those who care for them in your community. Yesterday, you should have received an email with a link to the pre-session evaluation questionnaire and a document titled Dementia Education Evaluation Information that further explains the evaluation. If you registered today or did not have a chance to complete the pre-session questionnaire yesterday, we invite you to complete this now using the link provided in the chat. I now have the pleasure of introducing our keynote presenter for this morning's presentation, Marty Wellman. Marty is the Program Director at the Ohio Council for Cognitive Health. She holds a Bachelor of Science and Nursing degree from Madonna University. For the past 20 years, Marty has provided education and support to individuals living with a diagnosis of dementia, care partners, and professional caregivers through education programs, care consultation, helpline, early stage programs, and advocacy. In 2007, Marty, along with other Hancock County leaders, began efforts to create a dementia-friendly community. In 2016, Hancock County was the first community in Ohio to be recognized as dementia-friendly by the Dementia Friendly America Initiative. Prior to joining Ohio Council for Cognitive Health, Marty worked in hospital, home health care, and health education settings, as well as with a voluntary health organization. Please join me in welcoming Marty Wellman.
Thanks, Jenny. It's great to be with all of you today. Are you able to hear me okay?
Yes, thank you.
Great. Let's just get right into the objectives for this program. We're going to talk about, we're going to define dementia, talk about common types, and we'll also cover some key points related to dementia in individuals who live with an intellectual and developmental disability. Also, we'll describe how dementia impacts the brain, common changes that are seen in aging versus those that are seen in the early signs of dementia. We'll also talk about how dementia is diagnosed, including important other conditions to rule out in the process. And we'll also talk about important steps after diagnosis, along with dementia risk reduction strategies that we can all employ in our lives. And then finally, we'll talk about from education to action, steps that newly diagnosed individuals and care partners can take in order to facilitate that individual living their best life after the diagnosis. So when we talk about the definition of dementia, we first talk about what it's not. We say that dementia is not a specific disease. It's this overall term that describes a wide range of symptoms: short-term memory loss, changes in communication, and eventually problems that are severe enough that it impairs our ability to get through our daily activities. There are many, many kinds of dementia. In fact, there's over 80 different kinds of dementia, but Alzheimer's disease is the most common type. It makes up about 60 to 80% of all dementia. Now, there are, as I said, there are many other kinds of dementia. We hear about vascular or cerebrovascular dementia. That's probably right behind Alzheimer's disease in terms of incidence. But we also hear about Lewy body dementia, Lewy body disease, frontotemporal lobar degeneration. We hear about mixed pathologies where people actually live with more than one type of dementia, Parkinson's disease, Creutzfeldt-Jakob, Huntington's, late hippocampal sclerosis, and then alcohol-related dementia as well. You will be getting a copy of this slide deck, and the links, I just wanted to mention that the links that you'll find in the slide deck will be live, And I've included quite a few of those on the slide so that you can gain more information, and you'll have other tools with you at the close of the program. We don't have time to go into any of these other descriptions of other types of dementia, but there will be a few minutes at the end for some Q&A, and if you have any questions, please write those down and we can take them after the program. Brain changes that are associated with Alzheimer's disease are these plaques and tangles, and you may have heard of those terms. The plaques build up around the outside of the nerve cells in the brain, and then the tangles build up inside the nerve cells in the brain. Over time, those plaques and tangles will cause that nerve cell to die. And so with that, you get this tissue loss in the brain. So that's the hallmark of what happens in Alzheimer's disease. The pathology is a little bit different with the other types of dementia, but for the purposes we talk about, for the purposes of this program, I'll just refer to the plaques and tangles that are associated with Alzheimer's disease, since that is the most common type of dementia. I do want to point out that in individuals with IDD, particularly IDD is, I'm using short for intellectual and developmental disabilities. For individuals, particularly with Down syndrome, there is an added risk for Alzheimer's disease. And it's due to the extra copy of chromosome 21. That carries the gene that's responsible for the production of that amyloid plaque that I just mentioned. So I will make some references to mostly Down syndrome and Alzheimer's disease throughout the presentation. But you can see on this picture that there is significant change in the brain when a person has Alzheimer's disease. In this case, the picture is of advanced Alzheimer's disease. However, I always like to point out that there's a lot of tissue that hasn't changed. And interestingly, there are parts of the brain that don't change much when a person has dementia. And that's called the area of the brain called the amygdala. That's responsible for our emotions of love and our need to be included, to be treated with respect and dignity. Those areas of the brain don't change. So it's a very important message that no matter how far advanced the disease is in an individual, we must always, always, always remember that part of the brain that doesn't change. The prevalence of Alzheimer's disease is high and it's growing. Today, we estimate about 6.2 million Americans age 65 and older who are living with Alzheimer's dementia. And by 2050, that number you can see is going to grow to over 12 million individuals. I do like to always point out, though, that dementia, Alzheimer's and other kinds of dementia is a very underdiagnosed condition. We have a lot of individuals who live with dementia, and there's not a diagnosis on the chart. So keep that in mind. When you look at that 6.2 million number, we have to take into account that some estimates as high as 40% of individuals with dementia do not receive an official diagnosis, and it does not become part of their medical record. Now, key points about incidence of Alzheimer's disease in those with Down syndrome. The incidence is that Alzheimer's affects about 30% of people with Down syndrome in their 50s, when they're in their age 50. When they're in their 60s, that number comes closer to 50%. So the bottom bullet there, you can see that even though there is a risk with an increased risk with each decade of life for individuals with Down syndrome, at no point does it come close to reaching 100%. Okay, so those figures are 30% of people with Down syndrome when they're in their 50s. The incidence goes up to about 50% when they're in their 60s. In the general population, the incidence of Alzheimer's disease is about 5% in individuals aged 65 to 74. It's about 14% in people that are 75 to 84, and then it's about 35% in people age 85 and older. In Ohio, we have an estimated 220,000 individuals living with Alzheimer's dementia in 2020. And those numbers you can see are projected to rise quite significantly just in the next couple years. We lead the nation, unfortunately, in the incidence of Alzheimer's disease. If you're wondering who's ahead of us, they are states California, Florida, New York, Texas, Pennsylvania, and Illinois. It's Ohio's 6th leading cause of death, and you can see the hundreds of thousands of unpaid caregivers that it impacts. We estimate that for every individual that's living with a diagnosis of dementia, you can multiply that by 2, 2.5, or 3 in terms of individuals who will be involved in the care of that individual. So when we look at early signs and symptoms of dementia, we first want to acknowledge that these are really going to vary depending on the individual, the type of dementia that they have, the stage of the illness that they're in. And we also want to point out that there are many conditions that can mimic dementia. And it's very, very important that these be ruled out in the diagnostic process. We want to look for infection. And if you work in the field of dementia, you know that it's the UTI, it's the bladder infection that we first look for, because in older adults, that can be a significant cause of confusion and memory loss. So we look at infections, we look at Lyme disease even. We look for signs of malnutrition and vitamin deficiency. Certainly the effects of medication. The average number of prescription medication that older adults take is quite high. I believe it's 7 is the average number. And, to think that some of those aren't going to interact with each other, so I love to involve a pharmacist in the diagnostic workup of an individual to really take a look at those medications and look for interactions. We also have to look for head injury, brain masses, hydrocephalus, concussion. We want to rule out metabolic disorders that involve the pancreas, such as diabetes, liver and kidney, thyroid disorders, anemia. Pain can cause a person to be confused, especially chronic severe pain. It can interfere with our memories. It can cause us to be confused. Delirium, which is acute onset confusion, grieving, stress. Depression is a huge factor that needs to be looked at when we're ruling out dementia. The symptoms of depression can mimic dementia: forgetfulness, confusion. So that's, individuals should be screened for depression as part of the workup. Also, inadequate sleep. So, and excessive alcohol consumption. So this is a long laundry list, isn't it? Alzheimer's is not a quick and easy diagnosis. We don't have a blood test available to say yes or no. We can do imaging, but even that needs to be put together with other pieces of the puzzle to come up with this. I just wanted, before I go into the early signs and symptoms, I just did want to talk just really briefly about some of the risk factors, in case you're wondering about what some of those risk factors for dementia would be. And still, it is age. Even though the title of the program is Dementia, Not a Normal Part of Aging, that's obviously a very true statement, and it's actually one of the 5 key messages of our Dementia Friends program that I'm going to talk about in a little bit. But age still remains the greatest risk factor for developing dementia. Researchers have found several genes that increase the risk of Alzheimer's. Not, again, my language is they increase the risk. They're not definitive for dementia. And that would be the Apoe gene. We all everyone inherits one of three forms of the Apoe gene, and that's APOE. So there's an Apoe 2, 3, and a 4, and depending on your combination in your gene makeup, it can help physicians look at the your risk for dementia, for Alzheimer's disease. However, again, I want to point out that it's not a clear diagnostic definitive tool. Family history does play a role. There are some modifiable risk factors that we can look at, things like our physical activity, smoking, our education levels, our ability to stay socially and mentally active, our blood pressure, and our diet. Those are some of the modifiable risk factors. Obviously, we can't change our gene pool, but there are some risk factors in our daily life that we can look at. Just wanted to mention a couple of those things about risk factors. So let me go back to the early signs and symptoms here. When we talk about those early signs and symptoms, the first one that we talk about in the general population is memory loss at the level, this is important, memory loss at the level where it's interfering with our daily life. So forgetting recently learned information, repeating stories and questions, forgetting important dates and tasks and routines. Now, the early signs in the IDD population, those are going to be not so much the short-term memory changes, but we're going to notice changes in day-to-day functions, reduced enthusiasm for work, for social activities. We might notice some changes in the personality and the behavior. And also unique with the IDD population is new onset seizure activity, or new or increased incontinence and mobility changes, and swallowing difficulties. So the early signs in the IDD population are a little bit different than in the general population. What's typical? So as I said, well, I haven't said this yet, but we're all forgetful to a certain extent, right? What's the difference? Well, typical aging is we might forget a name or an appointment, but we remember it later. We might forget where we put our car keys, but we have the ability to kind of back up, retrace our steps, figure out where the car keys would be. So that's kind of that's a difference between typical aging and the first early sign and symptom of dementia, which is that memory loss. The second sign is challenge in planning and solving problems. So difficulty getting your groceries, shopping, keeping your medical appointments, scheduling your medical appointments, not renewing prescriptions or paying bills in a timely manner. These are some of the examples that you might see under this category. What's typical? We might occasionally make an error when we're balancing our checkbook, doing our financials. But again, it's troublesome when it's to the point where it's interfering with our daily activities. The third sign and symptom is difficulty completing those familiar tasks, whether they be at home or at work or leisure activities. Perhaps I am part of a card club, and now I have difficulty playing that card game, following the flow of the game, making decisions about that. It will become, as the dementia progresses, it will become difficult for individuals to meet their self-care needs in terms of bathing and eating and those basic activities that we talk about. Again, what's the difference between this and typical aging? We get a new TV, we have to set up the remote control. That challenge is expected with something new. The fourth sign and symptom are confusion with the time and place. Individuals eventually lose track of the day, the month, the year. They're not able to figure out what actually the correct date is. So this turns into missing appointments and events and so forth. Typical aging is we occasionally get confused about the day or the week, but we're able to figure it out, ask somebody, we're able to recall it later. The fifth symptom is trouble understanding visual images and spatial relationships. And individuals aren't always aware that this is actually a sign or can be an early symptom of dementia. So locating where things are in space becomes difficult. I might run right into that coffee table that's in the middle of my living room because of my dementia, my eyes and my brain don't coordinate. I'm not able to judge exactly where that coffee table is. I might see it as being a foot or two over to the right than where it actually is in that space. So driving, obviously, judging distances will affect driving. Even things like dialing a phone, operating equipment can be a challenge with the changes in the visual images and spatial relationships. The sixth sign, new problems with words, both speaking and writing. At first, individuals may have trouble coming up with the right word. They may forget a name of a person or an object. And then it becomes difficult for individuals with dementia to track conversations, to participate in conversations. And again, if you recall that image of the brain that I showed you, and I pointed out that there's an area that doesn't change, and that's the amygdala. That's the area that's responsible for our need to be included. And certainly, if I'm that individual, as my communication changes, that doesn't mean I don't want to be part of that conversation. It just means I'm probably going to be more quiet. I'm not going to contribute at the level that I did before, but I very may well still want and need to be part of that group. So we must, it's always want to include individuals and give them the opportunity for that. Misplacing things and losing the ability to retrace steps, putting items in non-typical places. The eighth sign, decreased or poor judgment. And unfortunately, this particular symptom can cause a lot of concern for safety, financial exploitation, walking away, driving away, and getting lost. All sorts of, you can imagine, changes with judgment and decision making can really impact that person's ability to get through their day. Withdrawing from work or social activities is another symptom that sometimes people aren't aware of. That disengaging from social community groups, changes in work abilities, refusing to allow visitors into the home as the dementia progresses. These can all be early signs and symptoms as well. And then finally, change in mood and personality. Sometimes we see a big shift in personality, a lot of change with mood swings, and other times we see very little. It just, again, all of these symptoms that I talked about are really going to vary according to the individual, the type of dementia that they have, and the progression of the disease, what stage of the disease that they're in. But nonetheless, this is just kind of a general overview of those signs and symptoms. When we talk about diagnosing dementia, we want to include, obviously, the person, but also family members, friends, other close acquaintances. We want to ask them about changes in their day-to-day abilities, there any kind of new prescription medication that might have been ordered, and even, it's really important, over-the-counter medications too. Even their nutrition, has that changed? Is their nutritional status changed? We want to ask about past medical problems and just how are they getting along in their day-to-day activities right now? Have we noticed any change in behavior or personality? So just really starting with a good review of what's going on right here and right now in terms of daily activities for that individual. And then there are cognitive tests. Some focus on memory, problem solving, attention. Some of the tools will assess ability to count and language skills. Some of the tools will have individuals name as many animals as they are able to come up with in 30 seconds or a minute. So each test is a little bit different. You see some of them listed here: the MMSE, the Minicog, the SLUMS, the MoCA, the RUDIS, and the SAGE. Probably some of the most used are the MMSE. However, I do want to point out that this tool was developed about 40 years ago, when our understanding of things like MCI, mild cognitive impairment, and even early stage dementia wasn't as great as it is now. And the MMSE tool is actually weighted heavily toward the skills, the cognitive skills that don't change until later in the disease process. So I think the Minicog is gaining more notoriety in terms of screening and early diagnosis of dementia. That's a 3-minute instrument, and it looks at 2 different components: a 3-item recall test for memory, and then the clock drawing is part of that as well. The MoCA, that's a brief 30-question test, takes around 10 minutes to administer, and again, that's another frequently used tool in the diagnosis of in the screening and the diagnosis of dementia. Now, in individuals with IDD, there's a screening tool that we refer to, the NTG, Early Detection Screen for Dementia, and again, used in individuals with intellectual and developmental disabilities. So it's important to know what more of that exact screen would be for those in the IDD population who are being evaluated for dementia. We also want to look at medical tests, blood and urine samples. The urinalysis is going to clue us into, is this confusion? Is this change in behavior due to a bladder infection? Is the blood workup, the CBC, will help us identify the complete blood count, will help us identify, is this due to anemia? Is there an infection present in the body somewhere? The chem profile is going to look at our metabolic things like our blood sugar. It's going to test the blood sugar, the liver and the kidney functions, and then of course vitamin levels can be done. A thyroid check is very important part of this. And then there are brain scans, there are imaging that can be done. A CT is probably the most frequently done exam, along with an MRI. But also there's a PET scan, the positron emission tomography, that can be done, not always covered by insurance, so there are some limitations with the PET scan, as well as with lumbar puncture is used on a limited basis to check for levels of amyloid and certain types of tau protein in the cerebral spinal fluid. So these are some of the part of the diagnostic workup. But again, I want to emphasize that we need to rule out those other conditions, and that's what part of this workup is about. We're doing depression screens. We're looking at the lifestyle. Are these symptoms of confusion and memory loss, are they due to the fact that we're just too busy and the home is too unorganized, the person is too overwhelmed? We have to look at the whole big picture when we're looking at the diagnostic workup. Now, a lot of people will start with their family doctor, and a lot of people continue with their family doctor. Others will involve a dementia specialist, and those might be a geriatrician, a geriatric psychiatrist, neurologist, neuropsychologist, and these healthcare professionals that are listed here are oftentimes part of a memory clinic and memory centers. They're the Alzheimer's disease research centers that we have all around the country. We have some here in Ohio, and when you get a copy of these slides, this link will take you to a map of the states, and you can click and find that Alzheimer's disease research center in your area. And there might be one across the state line that's even closer for you. Again, a lot of individuals are diagnosed through their family doctor. They're managed through their family doctor. Other people seek out one of these dementia specialists. So, important steps after the diagnosis. So, a person's had this diagnostic workup. The diagnosis of dementia is given. The individual may be given the specific diagnosis, or they may just be given that overall term dementia as their diagnosis. I think it's always more beneficial to get more of a specific diagnosis if possible. And a lot of times this is done through those PET scans and more specific imaging and more specific testing. But some of the symptoms are going to change, as I've said, depending on if it's a Lewy body dementia, if it's a frontal temporal degeneration, if it's Alzheimer's disease or vascular. Some of those symptoms and some of our treatment plan is going to be different based on that type of diagnosis. So I've always been a big proponent of, digging a little bit deeper if possible and coming up with the exact type of dementia. And then after that, we can take steps to help ourselves if we're the one diagnosed, or help our family member, our friend. Really, I know it's cliche, but it is so, so true with dementia, to live their best life with this disease. Individuals after diagnosis live on the average of 8 to 10 to 12 years with dementia. There's a lot of life after the diagnosis. 70% of people that live with dementia live in their own home, or they live in a home with someone else. They are active in their communities. They're out and about. And so it's really up to all of us to help support those individuals in their day-to-day life. So for individuals after a diagnosis, we want to help them learn as much as possible about their type of dementia, whether it be Alzheimer's disease, Lewy body, vascular dementia, whatever it might be. And there are a lot of great resources out there. The Alzheimer's and Related Dementias Education and Referral Center, the Alzheimer's Association, the Alzheimer's Foundation. The list just goes on in terms of resources. And at the close of this program, I'm going to give you those resources with links to the website so that you can check those out. It's really important for that person with dementia to get regular medical care, especially if they have a comorbid condition. And most people with dementia also live with a comorbid condition: diabetes, hypertension, there's just maybe lung disease. So the better we can manage those comorbid conditions, the better we can manage the dementia. So keeping the blood sugars where they need to be, the kidney function where it needs to be, this is all going to require regular medical care. I also want to point out that the regular medical care is so, so important for the primary caregiver. Is that caregiver getting their blood pressure checked? Is their blood sugar okay? Are they at risk for depression? Is the depression being managed okay? So it's not only regular medical care for the individual diagnosed, but also for the care partner. Locating local and state services and support. And again, I'm going to give you a list of those resources at the end of the program. Let me back up to the regular medical care. You might be wondering, do we have any medications that are available for the treatment of dementia? We do have 5 medications. Those are Exelon, Razidine. I'm giving you the trade names here. Exelon, Razidine, Aricept, and Namenda. And then there's a 5th drug called Namzaric that is a combination of both the Aricept and the Namenda. So that's called Namzaric. We want to help people start with some legal and financial and long-term care planning. This is very, very important after a diagnosis. There are a lot of great resources through, again, through things like the National Academy of Elder Law Attorneys, the longterm care.acl.gov can help locate some of these services that are needing. Individuals should think about getting help as needed with their day-to-day activities, to remain safe at home, to remain safe on the road. Think about participating in a clinical trial, and there are easy ways to access and look around and see what kind of clinical trials are available. You can even type in there how far you're willing to travel. Is it 25 miles? Is it 200 miles? And it'll bring up the trials that are available in your area. Again, just staying as healthy as possible, managing those other conditions that people might live with. And then there are certainly some great tips for those who live alone with dementia and those who remain in the workforce after a diagnosis of dementia, who might be seeking some challenges with their current position. And there are ways that people can find assistance through their employee assistance programs, their HR departments, and so forth. For those that live alone, just identifying that support network, setting up that support network. Is there a neighbor who can check on the person regularly? Can they sign up to be part of an RSVP program in their community? Making sure that there's an emergency contact list that's available for individuals coming into the home that might need to find that list. Things like a pendant or a bracelet that helps an emergency response system. Those can all make it safer for the individual to remain at home longer and to remain safe and independent as long as possible. I know the time is getting kind of close here, so I'm going to move on to the next slide here about just a word or two about steps to reducing dementia risk. I think all of our audiences that I talk to are always interested in learning what they can do to reduce their risk of dementia. And again, this list also applies nicely for people that are living with dementia. Exercise is very important for everyone with or without dementia. And when we talk about exercising regularly, we're talking about getting at least 150 minutes of moderate intensive aerobic activity per week. So that would be the goal, at least 150 minutes. When we talk about eating a healthy diet, rich in fruits and vegetables, there's this saying, eat the rainbow, right? And so the brighter, the darker, the richer colors of that fruit and vegetable, the better. So I think of things like red beets and carrots and broccoli and collard greens and spinach, tomatoes and blackberries and cherries and figs. So the richer the color, the darker, the deeper the color of that vegetable or fruit, the better it's going to be for brain health. Let me emphasize that I want you to look at the title of this slide. It doesn't say ways to prevent dementia. It says steps to reducing our dementia risk. We don't have ways to prevent dementia right now. We're working on it. We're getting closer with the research. And thank goodness the research funding has really gone up in the last few years, the last 10 years. But for now, this is what we know on steps for reducing our risk for dementia, no matter what our age or our ability is. Spending time with family and friends. Socializing is the second best thing we can do for our brains. And I don't need to mention what COVID has done for our abilities to socialize over the last year and the detrimental impact that that's had on individuals with dementia and care partners, as well as our general society. So we have a lot of making up to do, don't we, in terms of socializing and getting back connected with others as we come out of this vaccine, or this, as we come out of this pandemic. So keeping one's mind active, trying new, complex, and novel activities, things that are new to you and a little bit challenging, controlling the type 2 diabetes, keeping your blood pressure and cholesterol at healthy levels. Now, I want to mention that, you know, for many, many years, our goal was to keep our blood pressure under 140/90. Those numbers have changed if you're not aware. Now we want to keep our numbers under 130/80, actually. So those numbers have really gone down. Those target ranges have really gone down over the last, you know, many, many years. Sleep is important. We're hearing more and more about the impact of sleep on our brain health. Again, the target is 7 to 9 hours of sleep a night. And I can't state it enough, this is kind of a passion of mine, is to get help for depression. It's not only important when you are looking for other causes of the symptoms of dementia, but for those individuals who live with depression, that increases their risk for dementia. So we want to control the depression. We want to treat that all throughout the individual's life, maintaining the healthy body weight, stop smoking, and then avoid drinking excess alcohol. So these are all steps that we can take. There's this nice little guide here that I'm pointing to now that sums all of this up. And this comes through NIA and NIH.gov. For resources at the state and national level for dementia, and in this list, I also included our important grant partners that are part of the work that's being done through the ACL grant. But you can see a list of different resources throughout Ohio, throughout the nation. Some are more for caregiving, some are more for care and support. Lewy Body Dementia Association, Frontal Temporal Dementia, or Dementia Association for those that are living with that type of dementia. So again, just a lot of great resources. The O'Neill Center, our organization is Ohio Council for Cognitive Health, and we're one of the grant partners on this, along with Benjamin Rose and others who are hosting this webinar today. Scripps Gerontology Center, and then the Athens Village, United Seniors of Athens County, and then Welcome House as well. A lot of great resources. After the diagnosis, it's important to really start establishing that network of help and support and care. And that network is going to be built more easily and more quickly when we involved these organizations that you see listed here. So, from education to action, Dementia Friends is this great program. Now that we have more education about dementia, a better understanding, hopefully, about dementia, what can we do? The Dementia Friends program is this global program. It's free. It's 75 minutes. We offer it virtually. We offer it in person. We can do a hybrid model of that. It's an interactive program that focuses on these 5 key messages and a call to action. People are challenged to think about what they can do as an individual to affect the life of others who are living with the disease. We have sector-specific options. So we have a Dementia Friends for IDD, a Dementia Friends for those that live alone with dementia, a Dementia Friends for faith communities, for legal and financial sectors of the community, even for libraries. So we've adapted the program a little bit for those specific sectors, and we're always adding to our toolbox, so to speak. But we hope that you'll take a look at this video, and you'll see that you'll have the link to click on that. The video does a nice little job of just explaining what Dementia Friends is about and how we can all get involved in our communities to really start that conversation, to really change the way that we talk and we think and we act about dementia. That's the core of the Dementia Friends program. And it's also one of the core components of this grant work that we're doing. And we're really excited to be part of that. Ohio Council for Cognitive Health, Dr. Bonnie Berman, and myself, we are the state leads for the Dementia Friends program. And we're very excited to be able to share that eventually with you on the call. Just my reference list here. And I think Jenny and Krista, I am at the end of my time allotment, so I'm going to stop here.
Thank you so much, Marty. We do have time for a few questions from the audience. Please remember to submit your questions using the questions box in the control panel on the right-hand side of your screen. So Marty, the first question that we received, could any of the signs for dementia that you shared come from taking cancer medications as well?
That's a great question, and all medications should be looked at in terms of, are they causing symptoms of memory changes, confusion, and certainly chemotherapeutics will fall into that area. That's about as specific as I'm able to address. It's a good question for the physician, for the pharmacist, but yes, there is the potential because it is a medication.
Thank you. Someone asked, what if someone can't move well or has regressed in their movement to only using a wheelchair, but they have no other diagnosed issues? Would this be Lewy body dementia?
And there's no other diagnosed conditions. Was that part of it, Jenny?
Correct.
Now, Lewy body dementia does seem to affect mobility more than some of the other types of dementia. However, all dementia in the later stages is going to affect mobility. So it's kind of hard for me to answer that question, but changes in mobility are accompanied by all types of dementia. So just, again, looking at that thorough diagnostic workup, asking questions of the physician, and really trying to sort out, is this Lewy body, is it another type of dementia?
Thank you. Someone asked, what is the connection between hoarding and dementia?
Oh, hoarding and dementia. That's an interesting question. Individuals with dementia, I will say, get overwhelmed easily. Most, I don't want to generalize, but most individuals with dementia have difficulty managing change. They get overwhelmed with noises, with things. It's hard to determine what piece of mail stays, what piece of mail do I need to keep for a week or 3 years. All this decision making around stuff, what we do with it. I don't know of any real connection between I don't think of hoarding as a risk factor for dementia. I could be mistaken on that. But certainly we want to help people take steps to reduce the clutter, to kind of minimize their living situation so it's easier to navigate around and less things to be bothered by.
Thank you. Somebody asked, how does one typically find a geriatric doctor?
Oh, another great question. There are some resources that I will make sure that you get. There are some websites that list geriatricians in your area. Unfortunately, we are lacking in the number of geriatricians that are available. So it can be a little bit difficult, but well worth the time and the effort to find that geriatrician. And it might come under the list of an internal medicine. Some family practice doctors specialize in geriatrics. So I will make sure that everybody gets access to that ability to find those resources for geriatricians.
Thank you. Someone else asked, is there a good way to talk to a person with dementia who appears to have paranoia, but who needs help and will not accept the help?
Yeah, just that constant reassurance, that constant support, not overwhelming the person with a lot of information at a time, just short bits, pausing, just being with the person. Again, offering that reassurance. A lot of times it's just a matter of waiting it out until some of those symptoms kind of subside. That's one thing about dementia. It's an ever-changing condition. So I always tell caregivers, don't think that this symptom or this behavior is going to last forever, because things are going to change for you. They're going to change for the individual. But certainly the suspiciousness, the paranoia can certainly be a big part of those with dementia. And we just want to not argue with the person. We don't want to try to explain things away. We just want to offer that support. We want to offer distraction, trying to change the subject. Those are, I could go on and on forever about this topic, but those are some different tactics that sometimes are helpful.
Thank you. And then I think we have time for one more question. Somebody asked, is Dementia Friends open to individuals with dementia that are out of state?
That are out of state?
Correct. And they specifically asked about, is it open to individuals with dementia that are out of state?
Yes, definitely. Dementia Friends is a program that's open to anyone and everyone, certainly those individuals with dementia. It's a program that gives everybody just kind of what they need. It doesn't go into a whole lot of depth on different topics, but certainly individuals with dementia are welcome at sessions, and we love to co-present Dementia Friends with individuals with other champions, but certainly involving those with dementia as well.
Well, thank you again so much, Marty, for your fantastic presentation, and thank you to our very engaged audience for your wonderful questions. Before we conclude today's webinar, my co-project director, Branka Premedica, is going to tell you briefly about BRI Care Consultation, a care coaching program available for families impacted by dementia in Ohio through the new Administration for Community Living project. Branka?
Good morning, everybody, and thank you for joining us today. As Jenny said, I'll talk a little bit about BRI Care Consultation. This is a telephone and email-based care coaching program that assists and supports adults with at risk for developing dementia, and it also includes individuals with intellectual and developmental disabilities. And another key feature is it also involves family and friend caregivers or other supports. This program is available at no charge to clients due to the generous funding provided by the Administration for Community Living. Next slide, please. So what is BRI Care Consultation? Well, essentially a personal care consultant is assigned to an individual or family to help with finding and getting connected to health and community services. And it really prioritizes the needs by utilizing a step-by-step plan to create to create steps on where to go next with care. Communicating with loved ones, family, and friends about care and managing difficult situations and behaviors. This program continues to stay in touch as well to make adjustments as a care situation changes. It also assists with getting other family and friends involved, and of course being there for individuals and families as an emotional support when faced with caregiving challenges with persons with dementia. Next slide, please. So this program is available in through the funding that's available through the Administration on Community Living. It's available in Athens County, Cuyahoga, and Washington County. As you can see here, in Athens County, United Seniors of Athens County and Athens Village are co-delivering the program. At Cuyahoga County, Welcome House and the Benjamin Rose Institute on Aging under the name of We Care Because You Do, as well as O'Neill Center in Washington County. As you can see, there are little golden stars next to all organizations except for Benjamin Rose. And essentially this means that the organization serves individuals with intellectual and developmental disabilities with or at risk for developing dementia. So essentially, there is no need to have an official diagnosis. It could be at risk for developing as well. There's contact information there, so we encourage you to contact these agencies to find out more information and enroll in the program. Next slide, please. I think that's it. Thank you, everybody. Back to you, Jenny.
Thank you so much, Veronica. Well, we want to thank you again for joining us for Dementia, Not a Normal Part of Aging. A recording of today's session will be made available at www.benrose.org on the event registration page and in our resource library. Shared in the handout section is a PDF version of Marty's slides that can be found on the right-hand side of your screen in your control panel, but we will send an updated version in an email that you will be receiving tomorrow. We will be offering more webinars like this for community organizations and families impacted by dementia each project quarter. So to stay up to date on dates and topics for these upcoming webinars, please visit our website. Again, that's www.benrose.org. We will also be sharing in the coming months information about Dementia Friends sessions, so please stay tuned. Later today, you will be receiving an email with a link to a post-session questionnaire. We ask that you complete the post-session questionnaire within 1 week following today's session. Your response will help us improve dementia education programs and help us think about future services and supports for individuals with dementia and those who care for them in your community. Thank you again for joining us and have a great rest of your day. Take care.